Hello and welcome to today's special clinical educational webinar hosted by Ambu. My name is Jason Cronwall and I am the Senior Market Manager for Ambu's A-Scope family of single-use bronchoscopes. Ambu is acutely aware of the ongoing challenges with the COVID-19 pandemic and is excited to bring this continuing education webinar to you this evening. Tonight's webinar is the third installment of a four-part live educational series covering topics related to bronchoscopy during COVID-19. In this series, experts from various disciplines are sharing their real-world clinical experiences performing bronchoscopy during the pandemic, providing perspectives on the latest society guidelines and statements, and offering suggestions on how to continue performing bronchoscopy while maintaining a safe working environment. In tonight's program, our presenter will review the key impacts of the pandemic, as well as discuss evidence-based approaches to safely perform bronchoscopy while maintaining the safety of the patient and healthcare team. I would now like to transition to our continuing education program and introduce our presenter. Before we get started, I'd like to orient you to the functionality of the Zoom webinar system that we're using today. Today's program will be recorded and made available on our website. During the presentation, all phone lines are automatically muted. If you have a question for our speaker, please feel free to post questions via the Q&A function, which is located at the bottom center of your screen. Our guest speaker will answer as many questions as time permits. This webinar is accredited for 1.0 hours of continuing education credit awarded by the American Nurses Credentialing Centers Commission on Accreditation for All Nursing Professionals. Terry Goodman and Associates is an approved provider of continuing nursing education by the New Mexico Nurses Association. Nursing professionals will receive an email by Terry Goodman and Associates within 5 days of the conclusion of today's webinar program. In addition, Dr. Garrett has generously created an ebook full of COVID-19 resources and also has provided the webinar slides that are located in the Files section of the webinar software. Now it is my pleasure to introduce our expert speaker for today's webinar. Dr. Hudson Garrett is the President and CEO of Community Health Associates, LLC, and has a faculty appointment as the Adjunct Assistant Professor of Medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine. He also co-founded the nonprofit, the Infection Prevention Institute, to help shepherd dissemination of best practices of infection prevention and control across the healthcare continuum of care globally. He is board certified in patient safety, healthcare quality, endoscope processing, and infection prevention and control. He has served on expert panels related to disinfection, sterilization, and endoscope processing within both the FDA and EPA. Dr. Garrett has lectured in more than 25 countries and given testimony to government and regulatory agencies on a variety of topics related to infectious diseases. Dr. Garrett is also part of a specialized infectious diseases critical care transport team in collaboration with federal and regional public health authorities dealing with COVID-19. It's now my pleasure to turn the program over to Dr. Garrett to discuss tonight's important topic.
Perfect. Thank you very much, and good evening to each of you. As he mentioned, we really have an exciting opportunity before us to learn from what COVID-19 has provided us, but more specifically to look at how we can provide safe care. I do want to provide this important information related to the CE for tonight's program. In order to receive the 1.0 contact hours, you must attend 85% of this activity. If for whatever reason you're unable to complete the program tonight, we are going to make that available for up to 2 years on the website as well. Here are my disclosures since we're providing contact hours. And I'm going to jump right into the objectives for this evening's program. Part of this has already been covered during the introduction, but really we want to look at how do we balance risk versus benefits with bronchoscopy? And really, what are some of the key learnings that we've seen with COVID-19, and how can we sort of translate those into good, safe practices, not only for our patients, but equally as important for our healthcare teams and providers. And then lastly, we're going to look at some of the new guidelines and standards that have come out about aerosol generating procedures, such as bronchoscopy, as well as recommendations about how to properly care for COVID-19 positive patients that might require bronchoscopy either for diagnostic or therapeutic purposes. I have provided the CDC website, which is an excellent resource. This update, or this website, should I say, is updated on a frequent basis, usually twice a day. And it contains everything from clinical practice recommendations, infection control recommendations, laboratory testing, and beyond. I want to start with, I think, a little bit of the journey as we've sort of seen with COVID-19. And unlike any other pandemic or any other major outbreak, this one has had tremendous financial implications, but also we're starting to understand the clinical implications where patients have not been able to seek or receive care. Part of that was due to fear, quite frankly, because they were afraid to go to hospitals or to clinics. But more importantly, there's also fear amongst the healthcare community. And when you look at this graphic that was really looking specifically at the impact of pandemics, this is going to go far beyond the financial cost. One of the things that we've not fully appreciated yet is sort of the mental toll that this is taking on healthcare providers and sort of that fear factor. We're going to talk about how to mitigate some of that as it relates to bronchoscopy with some good evidence-based strategies. Now, the impact has gone beyond that because it not only has caused a lack of access in some cases, but we have patients and healthcare team members that have sort of turned to the wrong areas, if you will, due to the stress caused by the pandemic. We also recognize that patients with tremendous comorbidities, those with our COPDs, our emphysemas, other chronic respiratory conditions, may be worsening because they're not able to receive that normal follow-up care that they have. So how do we really move forward in an era where we have a novel virus that, frankly, we don't have a treatment for, we don't have a vaccine for, and we have somewhat of a limited understanding of its full impact? Well, this is a scary time, right? This is a situation that we were in several years ago with Ebola, and before that MERS, and before that SARS. And so it's not that we have novel viruses that are totally new. We do have some experience with these. And COVID-19 is the illness that's caused by the SARS-CoV-2 virus, which is in the coronavirus family. So when we think about tonight's program, I want to ask ourselves a few core questions. The first is that procedure medically necessary for the patient, right? That's one of the most fundamental things that we should always be asking outside of just pandemics. The second is, are we going to use this for diagnostic confirmation of COVID-19? Are we going to use this for some type of therapeutic intervention, right? And then one of the next things I have to think about is about my staff and their exposure risk. Or am I going to use a reusable device that's going to have to be reprocessed, handled, stored, transported? Or am I going to move to a disposable device that's going to eliminate not only the risk to the reprocessing personnel, but that potential risk of transmission to that next patient? Having spent the last 4.5 years working specifically with trying to improve the safety of flexible endoscopes, I can tell you I've seen some pretty challenging situations where, despite good reprocessing efforts, the endoscopes are not properly cleaned and they come out with contamination. And then the last two are really looking at sort of the settings and resources that I have available to me. Do I have a room that's an airborne isolation room with that negative pressure? Do I have the ability to block the schedule to allow some of these particles to settle so that we can properly clean the room? And last, but one of the absolute most important situations that we have to consider is, do we have adequate PPE to protect our staff? So let's talk a little bit about the impact of COVID and sort of the evolution, if you will. Now, in February, I gave one of my first webinars on COVID-19, and this slide had 3 symptoms. And it since has expanded. It seems like every single week we have additional things that are added to this. If you think about the respiratory system, things like new loss of taste or smell. And so these are all symptoms that we have to consider that can frankly mimic so many other things that we might commonly come into contact with. So how do we screen for that? How do we make sure that patients that do sort of seem positive for COVID or have symptoms, we can actually handle that appropriately? Now, this is the data that I pulled earlier today to look at the total number of global cases versus the total number of deaths. You can see that this number on the left especially continues to escalate. As we put more testing into the market, we will continue to see escalations of that. One of the things that I'm always carefully watching is not only the total number of new cases, but I want to know what percentage of those are positive. I want to know, do we have enough healthcare resources, right? And what are the death rates? And if all those numbers are trending in the right direction, then that gives me a lot more optimism. Now, for tonight's topic, we're really thinking about that respiratory tract, the ability for COVID to survive there, the use of a bronchoscope or other types of procedures that might need to be performed. And as we enter into the next few months, we're going to have a challenge, which is sort of that concurrent influenza season, right? Where we have very similar symptoms that might present from a pulmonology standpoint in the same clinical presentation. So the good news is that CDC has already been tracking influenza-like illness across major metropolitan emergency departments to look for sort of clusters of symptoms and like illnesses. They've now added into that corona-like illness. And so we can really match this over with things like pneumonia, shortness of breath, and understand how are we doing in those local geographies. This is important when you think about reopening your practice or scaling back up your practice or doing procedures in the hospital to understand what that sort of local situation might be. Now, when we're handling a flexible endoscope, something like a bronchoscope, we need to think about how does that pathogen get from one place to the other? How does it get from the patient to the device, from the device to another patient, from the device to maybe a reprocessing worker or an environmental surface? And it really starts and ends with the patient being at the center of what we're trying to do. All we're trying to do here is break that chain of transmission. And there's many ways that you could do that. So if we think about sort of the core elements of COVID-19 transmission, we know we need to wear a mask. So if we have a mask on and the patient has a mask on, that's source control, and that's going to help break that mode of transmission. If we then cover our eyes, for example, we cannot expose our mucous membranes, and we hopefully will not have transmission of COVID. If we take that a step further, what about a reusable device like a bronchoscope? And if let's say that that device actually becomes contaminated and it's not reprocessed correctly or something is left behind and then it's used on another patient, we have great historical data, not just in the bronchoscopy space, but in the urology space, as well as in the GI space that says these endoscopes are not very successfully reprocessed on a routine basis. And so it really sort of drives the question of what can we do to sort of decrease the risk to the patient. Now, as it relates to tonight's topic of COVID-19, we're in sort of this limbo of how do we fully appreciate the route of transmission of this virus? And there's been a lot of misinformation, a lot of very controversial literature that has been published out in article space, if you will. And when we look at the majority of the transmissions of COVID-19, it's really droplets. We're seeing these aerosols and droplets that are fairly large particles that fall to the ground after a period of time. Now, there is data that says that some of these droplets can be suspended in the air for up to 3 hours, right? And we don't know how often that happens. But when we think about the true definition of an airborne transmission, something like tuberculosis, where if you're in a room, about 90% of people will become infected with tuberculosis. That's not what we're looking at here. And some of the recent data that's come out has specifically identified RNA that's left behind, but no viable virus. And so this is important to note as we think about the risk of doing a bronchoscopy. The CDC's put out 8 basic things that we can do to really mitigate some of the risk associated with COVID-19. The first is to make sure that we don't get exposed in the first place. And so this can be done through the proper use of PPE to make sure that we screen people. Maybe there's a high-risk procedure that we need to do in a negative pressure room. We always want to make sure that we're screening patients and our staff members appropriately. Number 2 should be no surprise at all. Standard precautions have expanded to be really more of that droplet and airborne precautions. If you look at sort of the best practice scenario, we need to be wearing some type of respirator mask that's rated for use in healthcare, preferably fluid resistant, right? But also eye protection. For myself, I use an elastomeric respirator, which I'll show you an example here in a minute, and I use a face shield. And that works extremely well for me. It's very comfortable and it's great for procedures like bronchoscopies. Keep in mind that the use of a mask plus a face shield is going to give you a very, very high rate of success at mitigating any potential issues associated with transmission. The next one is really looking at access and movement within the facility. Part of this goes back to if you're a physician joining tonight, making sure your residents and your fellows don't have them in the room unless they absolutely need to be there. And we, again, want to balance that learning experience with the use of PPE, especially for facilities that have very limited PPE supplies. And engineering controls, like putting up some type of barrier, using a disposable device, things that are going to help eliminate that risk or reduce that risk are going to be extremely important. Now, we are also at risk for contracting infection. I've had several friends, unfortunately, that have contracted it. My own sister-in-law contracted COVID-19 and works in a healthcare facility. And so we have to monitor ourselves and ensure that we're properly trained, we're disinfecting the environment around us, and that we're working with our infection preventionist as well. Now, one of the first things that we're going to talk about as it relates to new recommendations is patient and staff screening, right? And this is a hot topic right now because especially a lot of hospitals are demanding that patients be tested. And there's some good and there's some bad to that. But when we look at general screening, this applies to both us as the healthcare team, but also our staff. We want to make sure we're looking for the presence of any symptoms that might be COVID. We want to check for a temperature. I don't know about you, but I found that the no-touch thermometers are complete crap. Most of them give you a very inaccurate reading. And so that's problematic for us. And then we also want to ask questions about exposure history. So, for example, I went to a facility the other day and they screened me in the emergency department and they said, well, have you been around anyone with COVID? And I checked yes. And then she made the mistake of asking me how many patients. And I said, well over 800. And the eye and the sort of roll of the eyes, if you will, that I got was pretty impressive. But we can also look at staff and patient testing. And I'm a little bit hesitant to recommend general staff testing, but there is some good data that suggests patient testing prior to an elective procedure is helpful. Now, unfortunately, with sort of the challenges we have with testing right now, what many facilities are doing is doing testing 72 hours prior to an elective procedure. And then they're advising the patient to self-quarantine at home. Well, we all know that that's not always going to happen. And so we really need to come up with a better mousetrap, especially for emergent procedures. Let's say you have a patient in the ICU that needs an emergent bronch. It would be ideal to be able to do a bedside test, point of care, get a result in 15 minutes, and really know what you're dealing with. These aerosol generating procedures have been classified by CDC as those high-risk procedures as it relates to COVID-19. And you notice that I've highlighted 3 here: suctioning, sputum induction, which of course is relevant to bronchoscopy, as well as the physical procedure of bronchoscopy. Notice that nowhere in here does it say that you should not do. It simply says that you essentially need to use caution. And so when we think about aerosol generating procedures, just as we would do with tuberculosis or anything else that would be similar to this, we always need to take the appropriate precautions with PPE. Now, those evidence-based practices are really looking at what might be done. Are we going to generate any type of sputum production? Are we going to do a deep suction? Are we going to do any type of lavage? All of these things play into what that risk may be. And again, if we go back to good use of standard precautions, making sure I have my gloves, my gown, my mask, as well as my eye protection. And really, again, I can't strongly suggest enough, face shields are really the way to go here. This is going to help limit that exposure. The other thing we want to do is not bring extra people into the room unless we absolutely need to. And again, I want to balance that with the fact that we have a teaching obligation to the students that we serve. Now, if we transition a little bit, there was, as you can imagine, a lot of fear around, well, should I do a bronchoscopy? What would be the safe practices to do that with? And so these new guidelines came out that really were looking at relative risk related to bronchoscopy with COVID-19 patients, and really some pragmatic and rational approaches to make sure that you can reduce that risk. So let's sort of walk through these together. And I tried to separate these into things that are more core versus the advanced topics. So when we think about some of these core recommendations, there's some very common things on here, like don't induce sputum collection if you can help it, right? And we do not want to routinely use a bronchoscopy for the diagnosis of COVID-19 unless there's some specific reason. So that is something that is really an unnecessary risk. But we do want to look at stratifying procedures that are urgent, things that can wait but not that long, and things that are truly elective, and concentrate our efforts on the procedures that need to get done that are going to cause patient harm or result in harm if they're not properly done. But anytime we deal with the lungs, we have that potential for an aerosol generating procedure. And this is really where it's gotten sticky, especially with CDC, where there's been this misconception that an aerosol generating procedure means that you can't do it. And so again, we want to go back to those core questions I asked earlier. Is the procedure medically necessary for the patient? Is it going to be therapeutically beneficial for the patient? Is there some type of diagnostic that we need to do? And there's been several papers that have come out recently that have really highlighted the need for bronchoscopy for diagnosis of other things beyond COVID. And so we don't want to sort of narrow ourselves and silo in strictly on COVID, but really look at the diagnostic sort of therapeutic benefits, if you will, of bronchoscopy. Now, think about intubated patients, right? These are the ideal situation because we have a little bit more of a control there. And of course, we can have more of a controlled circuit. But anytime we're going to be exposing something, whether it's the circuit, this could be with your anesthesia staff as well, collecting a laboratory specimen, we need to make sure we're being very, very cautious about how we do that. I just went to the dentist for the first time, I think it was about 2 weeks ago, and I was blown away at how much PPE they were wearing and how they were so attentive to issues. And it was interesting because my hygienist said, this is the number one riskiest profession right now. And it truly is. Dental hygienists are at the very top of the potential for contracting COVID-19 because of the amount of aerosol generating procedures that they do. And it was interesting because I normally have my teeth polished with this. I don't know what the technical name of it is, but essentially it produces aerosols. And she said, well, we can't do that today. And yet then they had an issue with their other equipment and then they ended up using it. And I said, well, what are your procedures for aerosol generating types of things? And she said, well, we wait for 15 minutes, we spray everything down, but they have no special ventilation system. And we're a lot more fortunate in some of the periop environments that we have. So safe bronchoscopy can be done, right? And there's a couple basic things that we'd want to think about as it relates to stacking the deck in our favor. And many of these are referenced both in this guideline, but frankly, in some of the CDC recommendations as well. The first thing is to look at having an airborne isolation room, right? That negative pressure environment is going to help pull some of these things out of the environment and reduce that risk to the staff. It'll also help with air turnover. So our goal is to make sure that we don't infect other patients or frankly, staff members. And you always have to be vigilant, even if you're only around colleagues. And this is one of the areas that I've seen a lot of opportunity for improvement, where you'll have a patient that is coming down, but there's no patient there yet. So all the staff have their mask off, but they're around each other. Right. And so we have to think about, these recommendations are not just for the patient interactions. They're also for us as a healthcare team to make sure that we're not getting each other sick. The other thing is to look at the different types of respiratory protection and precautions, and we're going to go through these in detail. That could be an N95 mask, certainly eye protection. There's PAPRs, there's elastomeric respirators. So these PPE pieces of equipment are only as good as they're properly used and fit tested. So if you have a respirator, you need to be fit tested. And you may change the size of your face. You may shave your beard, for example, if you're a male. There's all different factors that go into ensuring that secure seal is present there. One of the unfortunate things that CDC's realized is that many of the healthcare workers that have contracted COVID that did truly get it in the healthcare setting, it was primarily due to improper removal of their PPE. And so it's important to put this stuff on, but to remove it correctly and immediately wash our hands. Another recommendation that came from this particular guideline was the use of a disposable bronchoscope, right? Anytime we can get to that sort of single unit of measure where there's not going to be any contamination risk and the device is supplied sterile, this is a huge win for the patient safety arena. And so this is really that first line defense, especially for COVID patients, right? And we've seen this transitioning in the GI space. We've seen this in the urology space. We've seen this in other places like disposable blood pressure cuffs, right? Little simple things where we can mitigate risk by eliminating the potential for transmission from patient A to patient B. And all of your regular disinfection processes, your HLD or your sterilization, regardless of what you're using, are going to be very, very helpful here. Coronavirus is extremely easy to kill, so that's a good thing. And the last piece that I'll mention about this particular guideline was they did a really nice job, I think, of breaking up what's urgent, what's emergent, and what's non-urgent, right? With the goal of saying, how do I prioritize my return to work clinical schedule? What should I be doing at the bedside? What should I not be doing? How do I sort of stack that deck again in favor of ensuring the safety of my patient and my team? right? And so there may be certain circumstances where, yes, you previously did a bedside bronch in the ICU, but now you may want to take them to a negative pressure procedure room so that you have a better chance for containing any potential aerosols. So I'd like to use the remaining time that we have together to talk about some of the core things that we can do to ensure the safety of our patients as well as our team. Number one is you can invest in a sustainable respiratory protection program, right? You're not going to catch me dead in a GI lab or a bronchoscopy lab without a respirator on right now, period, right? We're not taking a chance, especially in the bronchoscopy space. You're at very, very high risk of being exposed to aerosols. So it only makes sense. You're called out in the CDC guidelines as an aerosol generating procedure. So work with your infection preventionist if you don't have access to respirators, and that should really be your standard of care. The advantage of these reusable elastomeric respirators, like what I'm wearing here, this is actually my mask that I took a picture of, is these are completely reusable. It gives you total control over your respiratory protection. We should never be in a situation like what we have been, where we have healthcare workers that are going to work with improper, inadequate, or frankly, missing PPE. So I did want to give a couple of examples, and I sort of stack these into tiers based on what I would recommend considering. The first, and of course most economical, is the disposable N95 respirator or higher, right? These are, becoming a little bit more available, but it's still a challenge to get these. And remember that these were only tested and designed for single patient use. Yet many healthcare facilities are reprocessing these UV light, using UV light on them, a variety of different reprocessing solutions. These masks were not designed for that. And so that's sort of that disposable solution. The second tier, which is really where I see a lot of value, is a reusable elastomeric respirator. The advantage is that you can give every physician and every nurse and every tech their own respirator and they're good to go. That's their dedicated respiratory protection, because what we've seen with the pandemic was that we had massive interruptions in clinical care delivery because we couldn't actually, practice. Healthcare facilities were shut down. We need to do better about that to make sure that there's not an interruption in critical clinical procedures that might need to be there. And lastly, is there's that opportunity for a PAPR. I really like the PAPR, especially for the use of bronchoscopies, because it gives you sort of that total solution, and it's very, very comfortable. Not the most cost-effective thing, but it is something to think about. Furthermore, the CDC went down into a little bit more detail and talked about some procedures, like the use of a nebulizer or high flow O2, that really, based on the data that they have, they're uncertain as to whether or not there's any type of infectious aerosols. Now, I'll just pick on nebulizers for a second. You notice that it's starred because theoretically, the aerosol that's coming out of a neb is from the medication, not the patient. And so there's really a lot of information that we have to learn about this. But our goal clinically should be to never withhold the best possible care scenario simply because there's that risk. And again, I've hopefully given a couple different ideas about how we can mitigate risk as we go through this type of procedure. The second thing that I'd like to mention is building a service line pandemic plan to make sure that you can operate your bronch lab continuously, right? Having clinical operations in place, a staffing plan, making sure that you have PPE that's dedicated to your department, the use of an airborne isolation room, which may or may not be where you normally scope. Right? And then certainly looking at the types of bronchoscopes that you use. If you're using reusable, especially for COVID-19 patients, the guidelines are suggesting to use a disposable, right? And anytime I can get a sterile disposable device, that is a huge win for the patient, because it's going to eliminate that risk of contamination between patient A and patient B. The third thing that we have to think about is our labs, right? The areas in which we're operating and doing procedures, we need to make sure that that thing is as clean as possible. There are lots of different solutions, whether it's ready to use disinfecting wipes, sprays, or a picture here like an electrostatic, but there is a list of disinfectants that's published by the EPA that are known to be effective against coronavirus. So please make sure that whatever product you're using is effective against coronavirus. This will help knock down any potential risk of getting contamination from the environment itself. Number 4, we've talked about this several times, you've got to cover your eyes. This should be an all the time activity, right? If you're in the building, eye protection and mask all the time. We should never be wearing a mask and not eye protection. They go hand in hand. And yes, we've had people that have sort of not done this in the past, But, this is a time for us to be reminded of how critical covering all of our mucosal membranes is. And again, I really strongly recommend the reusable face shield because it gives you that more sustainable approach. We can also look at medical errors. We are going to continue to see errors as it relates to the treatment of COVID patients. We are still learning. I was talking to a colleague the other day, and he said, I'm so sick and tired of CDC changing their guidelines every freaking week. And I looked at him and I said, you do understand that in medicine, we're practicing evidence-based practice. And evidence-based practice means that we should learn from our most recent evidence and continue to evolve our practice. And I will be the first to say, I've got lots of friends that work at the CDC. They have not been perfect in this response by any means. But I do absolutely commend them for the amount of information that they put out, whether it's for us as a consumer, if you're going to get on an airplane, go to a restaurant, or have a critical procedure in a hospital. And so it's really all about transparency, making sure that if we have staff members and colleagues that are ill, we incentivize them to stay home. We must make sure that we're trained before the next pandemic, right? That includes the use of PPE and doing simulations so that when you're actually scoping a patient wearing a PAPR, what does that feel and look like? It's very, very different than if you're just doing it with your normal process. Tip number 7 is all about PPE. You'll notice on the left is sort of that preferred use, and on the right is what they call the acceptable alternative. Right. And that is kind of an interesting statement, if you ask me, because the preferred PPE is actually what you should be using. Whereas the acceptable alternative, you'll notice the difference is that you're not wearing an N95 respirator mask. And so it's not to say that these are equivalent. It's simply recognizing that there are tremendous ongoing supply chain issues. And this goes back to why we don't want to have extra people in the room, because we don't want to be using PPE for no apparent reason. So the room should really be limited to those people that are clinicians that are going to be involved in the care of the patient, right? And there is a new burn rate calculator if you've not seen it. It's available on the CDC website, and I'll be happy to email it to anybody that would like it, that helps you calculate how much PPE you will need based on your procedural volume. So if you're a bronchoscopy lab that's doing, let's just say 600 procedures a year, then you can multiply that out times the total number of staff that would be in the room, and you can get a very, very reasonable estimate as to what types of PPE you would need and how much you would need. Number 7 should never be a surprise when we talk about infectious disease, and it's no surprise here with COVID. If I'm touching a cart, a monitor, a blood pressure cuff, the patient, or any type of device, we need to get to 100% hand hygiene compliance. We know that COVID can be spread this route, and so it's important to really disinfect our hands with soap and water or an alcohol-based hand rub. Keep in mind that the FDA has recalled over 75 different alcohol-based hand rubs that are causing methanol poisoning. So please make sure that whatever you're using hopefully is a regular commercial product that is safe and effective. And so that's something that we have to think about. Now, as it relates to the bronchoscope itself and the use of PPE in the lab, if you look at this triangle, we're really looking at sort of at the very top, what's the most effective control mechanism versus at the very bottom, which is actually the least effective. And so when we think about PPE, where there's been so much focus in healthcare, that's actually the least effective thing that we could do. If we think about what people are doing in offices and grocery stores, having an engineering control where I sort of isolate people from the hazard. Maybe I put up that plexiglass. And I was sort of joking the other day. I went to the grocery store and they had a piece of plexiglass right in front of the cash register, but they didn't have it around the other two sides of the cashier. And the problem is that when you went to pay, the credit card machine was at the end of the line and there was zero protection for the person bagging the groceries. And so this is really an idea of, well, this was probably an unintended consequence. They hit sort of what they thought was the biggest risk, but never thought about the full process. Now, if we can get to a point where we can eliminate that risk by, for example, having a single-use sterile disposable device, then that is at the highest level of controls possible. That's our most effective intervention from an infection control standpoint, right? And so we want to try to do that as much as possible. Part of that could be device. Part of that could be our process. Part of that could be some type of pre-procedure antibiotic as an example. There's lots of different ways to skin that cat, but we absolutely consistently know that with these reusable devices, there is that ongoing risk for transmission, as well as, unfortunately, transmission to us as healthcare workers. And I'm specifically calling out the safety of our reprocessing colleagues, where they're exposed to this, they're exposed to water, they may be blowing out that device, which can produce aerosols. And so we need to be very, very careful about the things that we ask our staff to do and ensure that they're in the best interest of the team as well as the patient. And tip number 9 is one that I focus on all the time as it relates to infectious diseases. People process product in that order. The first thing that we got to do is make sure the whole team that's involved in the bronchoscopy is properly trained. And that needs to be role specific. So the physician's responsibility is very different than the nurse, who is very different than anesthesia, who may be very different than reprocessing, but every single role matters. And we need to, again, make sure we're all aware of what each other's, is doing. And specifically that we're training as a team wearing anything that we might be wearing, such as PPE. The second is process. And again, this can go back to that sort of role playing, but adapt your clinical procedures now before you actually have to use them or do them wearing full PPE. This is something that every unit needs to do. If you're in a PAPR, it may be very difficult for you to see. It may be very difficult for you to, get closer to the airway if you need to be. So just play around with that and make sure that you practice in the attire that you will most likely be wearing. And last but not least is look at the device, right? Single-use sterile disposable is an option, but also having PPE. So even if you're using a single-use sterile disposable device, you still need to protect the healthcare workers from the things that the patient brings to the table, those intrinsic flora. And lastly is making decisions based on true data. And I'm not going to go into a testing tirade here, but there's essentially 2 different types of tests, that viral test and that serology. But what we found a lot of people are doing is they're taking the serology test and self-determining that they're immune, and therefore they're sort of relapsing and not taking the necessary precautions. And I've seen this with colleagues as well. And remember that the specificity and sensitivity of these tests is not perfect either. And so we've got to do a better job of screening patients, really looking at localized data and planning our procedures accordingly. The American College of Surgeons and Ambulatory Anesthesia put out a position statement, sort of a guideline, if you will, looking at safe reopening of procedural areas. Many of the things that are mentioned here should be no surprise at all, right? Safe distancing, making sure that there's universal source control, limiting visitors, ensuring that the staff are wearing masks, especially for bronchoscopy, you really need to be wearing a respirator, right? Any of these aerosol generating procedures are sort of that highest possible risk. If you don't have a negative pressure room, you could potentially look at a portable HEPA filtration system. And there's lots of different solutions to ensure the safety of your staff. And then think about the locality, right? There's certainly that localized awareness and there's that preparedness. And the preparedness is most likely done at the facility or the health system level. But we need to ensure that our department has the necessary equipment availability. So for example, if you're a bronchoscopy team, let's say there's 3 physicians and 4 nurses and a couple techs, and let's just say you're a team of 10, it might make sense for you to get PAPRs so that you have that long-term sustainability associated with that. And that will help eliminate the risk to you as a healthcare worker. And then looking at changing your device from reusable to disposable is going to help reduce the risk to the reprocessing personnel, right? And it's going to help with equipment availability and turnaround. We've got to be very careful about how we do things in our clinical process to mitigate risk. And that's really going to help us do a couple of things: deliver safe and high quality care, but also make sure that we can maintain our clinical standards of care by delivering upon our promise to the patient with a timely procedure when medically necessary. And yes, we've been doing these procedures when there's emergencies, but there are also ways for us to re-engage with the patient to ensure the safety of every single person involved. So we've talked about a lot of information tonight. I know the first webinar that was hosted really talked a lot about sort of the challenges and frankly, the variations between clinical practice. Hopefully tonight's program has given you a couple different ideas that you can start implementing tomorrow if you've not already done so. And one of the first things is really building that preparedness contingency, ensuring that we have the necessary personnel, that we've cross-trained them, that they're competent in their specific roles. They know how to operate those engineering controls and use PPE, right? The second thing is that we have to make tough decisions. Those decisions need to be made on, do we have the capacity and the capability and the ability to safely reopen, right? And so we don't want patients to not receive the therapies that they need. But at the same token, we have an ethical and really a professional obligation to our teams to ensure that everybody is going to be as safe as possible, right? And that really leads to that next point about not withholding care. If the patient needs a bronchoscopy for a diagnostic purpose, let's do the bronchoscopy. Let's screen the patient. And if they're COVID-19 positive, let's take those additional steps that are necessary. But we don't want to withhold treatment from those patients. And really look at prioritization, just like in the guidelines about single-use devices. That can reduce the risk to the patient, that's coming beyond that patient, but also the exposure that would take place to reprocessing personnel. And again, we know through good data in the GI space that despite the best reprocessing efforts, there are a lot of gaps. And so we really need to be very judicious about how devices are reprocessed, or better yet, just eliminate reprocessing from the equation altogether. And then lastly is look at a pragmatic approach, things that are going to help us be better, collaborating with our infection preventionist, making sure we're prioritizing our patients based on clinical and medical need, that we've got readily accessible hand hygiene, we've got good techs coming in the room, cleaning and disinfecting the room, and we're isolating patients as needed. And this goes back again to those 3 Ps, people, process, product, having the right people doing the right job, following a sustained, highly reliable, safe process, and using the most efficacious and safe products that are available to us today. So as a reminder, if you would like to claim CE credits, you'll receive an email from Terry Goodman and Associates. It'll take about 5 business days, if not before, that you receive that. If for whatever reason you do not receive that, the email address to send an email to is listed there. We will get those information out. If you are not a nurse and are looking for a general certificate, one is available for you as well, and we'll be happy to provide that. So hopefully tonight's program has been helpful. I'll put up my contact information and turn it back over to the team to see what questions we might have through the Q&A.
That's great. Thank you, Dr. Garrett. At this time, we'll now open the program for question and answer from the audience. So as a reminder, to ask a question, just please type your question in through the Q&A function located at the bottom center of your computer screen. All questions will be answered in the order in which they're received, and I'll now allow Dr. Garrett to answer your questions that have been submitted. The first one, I'll read it out to you. What is the single biggest risk to healthcare providers from COVID-19?
That's a tough question, because I think it really depends on what you fear as the most. But really, probably the biggest risk is to patients or staff members, if you will, that have comorbidities, that really have vulnerabilities. Because what we've learned about COVID-19 is that it exploits the weaknesses that you already have. So if you have asthma, it attacks your lungs. If you're diabetic, it may attack your feet. And so we've got to be very careful about that. And there's also been a lot of stigma, believe it or not, with people that have either contracted COVID-19 and recovered, or, you've got a relative that does. And so I really think it's all about awareness and education. The good news about COVID-19 is if we keep it outside of the body, it's easy to kill. B is we can still provide good clinical care if we use the right PPE. And C is there's now new technologies available in the market that allow us to literally throw away the risk. And I think that's a very novel improvement. And if you look at the FDA's guidance documents as well as the CDC, one of the things that they've been screaming for years is single-use devices that will help us eliminate and throw away that risk.
Mm-hmm. That's good. Next question is, should we cancel elective bronchoscopies until COVID-19 is less problematic?
I think that goes back to localized data discussions in collaboration with your infection preventionist. If your local area has a positivity rate of testing of 50%, you probably would want to reconsider doing clinical procedures at this point, because that's extremely high. So really what CDC recommends is that if you have an area geographically that has very, very high rates of community transmission, then that should be at least a red flag, something that you should stop and consider before you institute procedures. But the majority of of things that we do, we can do safely. It just takes a little bit more attention to detail. So I would be very hesitant to recommend that. And I'll tell you why. Patients still need these procedures. We can't stop procedures just because we have a pandemic. And even if we get a vaccine that's highly effective in, let's just call it January, we really need to get between 70 and 80% of the population to receive that vaccine to get true herd immunity. And so we could be, not doing procedures for a year or longer. And so it's important to figure out a way to operate within sort of a relationship, if you will, with COVID-19, because it's not going away. We just need to make sure that we can stay safe and keep our patients safe.
Yeah. This is one that came through. Is there a correlation between early and often bronching a patient, a COVID patient, and patient outcomes?
It really depends. There's been some limited data about, diagnostic utility of bronchs as it relates to collecting specimens to look and see if a patient is truly COVID-19 positive. That's not a general recommendation if you look at the guidelines to do that. Obviously, that's a more high-risk procedure. But there is a lot of utility at using bronchoscopy to figure out, are there other things going on with that patient, or to thin respiratory secretions. One of the things that's unique about COVID is that it's almost like you need Drano in your pipes because you have to break up those respiratory secretions that become very, viscous and very thick. And so there is a utility in that as well as that suctioning process. And so there's lots of different ways. And I think we have to be careful to try to individualize the approach and make sure we're treating the patient and not the guideline. And that way we'll deliver that individualized care that's necessary for this, the high quality aspects of the patients.
Okay. Next question. What type of respiratory protection should our teams be wearing anytime we do a bronchoscopy?
Right now, I'm going to tell you 100% a respirator. So N95 respirator, a P100, an elastomeric, or a PAPR. That department, the bronchoscopy group, is it really at the highest possible risk besides respiratory. And so it's really imperative that if you do not have respirator mask dedicated to your department and you're doing procedures, that you work with your materials management department to do that. Again, I totally get the challenges with the disposable products, and that's why I'm really saying invest in elastomeric and give everybody one of their own, which is what a lot of hospitals are now doing for procedural areas, or invest in a PAPR, which can be very, very difficult to obtain right now, as you can imagine.
Okay. Next question. Do you think that all patients should be tested for COVID-19 prior to an elective bronchoscopy?
That's a good question. I think there is a lot of value in doing that, but only if it's value that is going to be truly appreciated at the time of procedure. So what I mean by that is what a lot of hospitals are doing, and part of this came from CMS's recommendations, was to do sort of that pre-op procedure screen. And they're doing that 72 hours out on average because it's taking that long to get the results of the test back. So let's say that your procedure is Friday morning and we test you Tuesday afternoon in order to get your results back. And we, beg you to please not leave your house, to not expose yourself to anyone else, to lock yourself in your room and isolate. And we know that in reality, that's not happening with patients. So our best case scenario would be to do a rapid point of care test the morning of the procedure if it's elective, or immediately before a procedure if it's emergent and we do have time. But there is some value in doing that for sure.
Okay. Next question. Is it safe to intubate patients that might have COVID-19?
I think the word safe is relative. I've done this. So, do I have a little bit of the hairs on the back of my neck up? Absolutely. But again, I'm following standard precautions, and it's honestly not a lot different than other respiratory diseases that patients might have. The only difference with this one is, of course, we don't have immunity to it. We don't have a vaccine. We don't have necessarily proven treatments from a therapeutic standpoint, but you can absolutely do that. Certainly the use of a face shield with intubation is strongly advised. The use of a respirator is a necessity here. So no surgical mask with these types of things. And ideally in a negative pressure environment would be great.
Mm-hmm. Mm-hmm. I have seen some people work up these look like homemade intubation boxes that go over the patient. What are your thoughts on that?
There's really not a lot of data that I've seen that supports the use of those. And, in talking to my anesthesia colleagues, there's a lot of difficulty in manipulating the airway using those. So I sort of think about my face shield as my box. It is protecting my face. It comes all the way down. I've already got a respirator on. I feel very, very confident in doing that. Now, certainly, if you don't have to intubate, let's not intubate. And we know that the outcomes for patients that are COVID-19 positive that are intubated and placed on a vent are not good. So we're really trying to back off of that. The Society of Critical Care Medicine has done some excellent work in trying to sort of scale off of vents and really look at high flow O2 and proning. So those are other things that we have to think about as priorities.
Okay. See, next question. What is the best way to screen our patients for COVID-19 to reduce the risk to our healthcare team?
Well, I will be willing to bet money that most healthcare facilities, and I'm really speaking from the experience that I've seen here in the greater Atlanta area, are strictly looking at temperature screening. They're not actually asking every single symptom question. They're not presenting the symptoms. And in most cases, they're not asking about exposure. So exposure could be a high-risk exposure to someone with confirmed or suspected. Maybe you were in a room with somebody that tested positive the next day. You went on a road trip with those people. So it's really all about asking those relative questions, but we've got to get away from just a temperature screening and do a thorough screening at the beginning of every single shift.
Next one, besides COVID-19, what are the other infectious risks that are associated with reusable bronchoscopes?
There's a lot of data that is out there that suggests that the majority of scopes have some type of contamination. If you look at sort of FDA's definition, they sort of bucketize, if you will, pathogens into two different buckets. The first is sort of those low or moderate concern organisms, and the second is high concern. Those high concern pathogens are the ones that we're concerned with as clinicians because they're pathogenic and they're going to cause disease to the patient. Those low concern organisms are most likely really contaminants, if you will, similar to what we get on the skin. And we're not near as worried about those, but if GI is even a small indication of the problem, combined with the data that we already have for bronchs, we know that reusable devices are very unreliably cleaned. And so it's not just a COVID-19 thing. Frankly, COVID-19 is a virus. And so it's sort of lower down on my totem pole of areas of concern. I'm much more concerned about things like CRE, some of those more multi-drug resistant bacteria that can actually form a biofilm on these devices. And so, if I think about it from a patient's perspective, if the physician walks in and says, you have two choices, one is going to be a reusable device and we'll do our absolute best to clean it. Or we're going to give you a device that's never, ever been used on another patient and it's sterile. And I can assure you of that. Really, what is the choice? I think that it really is about educating patients about patient safety issues and frankly, giving clinicians the power and sort of the talk track to have those conversations with patients because patients are educated. They want to know this information as part of that informed consent. And it really goes well beyond COVID. I think COVID is what we're talking about today, but how do we make sure that we stop transmission in general?
Mm-hmm. So I've got two questions related to your most recent answers, but let me ask the first one. So the question is, I've heard that the FDA conducted studies to evaluate contamination of GI duodenoscopes using ERCPs and found widespread contamination. What do we know about similar patterns with bronchoscopes?
So the study that I think the person is referring to is the 522 study, which was an FDA-mandated regulatory study specifically looking at contamination of duodenoscopes following ERCP procedures. And they actually looked at clean endoscopes. Now, there was no standardization as to whether or not it was HLD or sterilization. It was whatever the facility already did. The unfortunate news was that there were a large percentage of those devices that had been reprocessed, most according to the manufacturer's instructions, that still had some type of high concern pathogen. And while we don't know, what the true risk of a high concern pathogen is to every single patient, because that's individualized, that risk of transmission is there. And so we've got some equal data, not near as much, but we do have some good data. I mean, there's well over 60 outbreaks of bronchoscopes. I personally investigated investigated several myself. So there is data out there that looks at that. It's unfortunate that the FDA has not yet commissioned a similar study to look at reusable devices, but hopefully that will be something that will be coming in the future so clinicians can really appreciate that risk.
Mm-hmm. So the next question kind of relates to the previous question you talked about. So what should we communicate to our patients about how we will handle the bronchoscope to reduce the potential risk for contamination and infection during their procedure?
So it depends on if that device is reusable or not. If the device is reusable, you have to have a little bit of a longer conversation and talk about what are we doing? How are our personnel trained? What type of process is the device subjected to? How do you validate your HLD as an example? What about maintenance of that device? When was that device last inspected by the manufacturer? And we find that with reusable GI scopes and bronchoscopes, that historically there's not manufacturer recommendations as far as sort of the service interval. That has now since changed with ERCPs that are done with duodenoscopes, where the FDA has mandated 1 year maintenance. So every single year, those devices that are reusable come back in. But FDA put out a safety alert and said, try to move to devices that are either completely disposable or have disposable components and accessories. And I think that's a very strong move towards patient safety to get to those more disposable scenarios where we can totally eliminate the risk. Because if I walk in and I have the conversation that this device, along with all the other equipment used, is completely sterile, is only used for you and will be thrown away after you, that's a very different conversation from a risk management and patient safety perspective. And it hopefully will be advantageous for the patient to feel reassured that the hospital or facility is taking those necessary precautions.
Okay, good. Final question. Where can we learn more about accredited training for infection prevention and control?
There's a variety of different sources. So, your professional societies, many of them are part of that multi-society guideline. But frankly, the CDC has a ton of free information that is available, most of which has credits for nurses and physicians. So if you just go to the cdc.com website and type in the word train, just like it sounds, that is a free learning management system that has a whole host of courses. So if you're a nurse joining, a physician, you may have different responsibilities in the process, but every single person has a responsibility for awareness and accountability. And so, physicians need to be rest assured that the device in their hand is going to be safe. The nurse is going to be managing those clinical processes of the patient, just like anesthesia is ensuring that the airway's intact. So every single person has a role, and CDC's got training for each and every role that we deal with.
Mm-hmm. Great. Well, we've exhausted all the questions. So thank you, Dr. Garrett, for your insightful presentation. I'm confident that each of us can take valuable information from today's program back to our own clinical practice settings. So we appreciate you sharing your expertise with us today during this difficult public health crisis. We hope that everyone on the webinar enjoyed the program. As a reminder, nursing professionals will receive an email from Terry Goodman and Associates within 5 days of the conclusion of today's webinar program. If you have any questions regarding claiming your continuing education credit, please contact continuingeducation@chassociates.com. And mentioned at the beginning, this webinar is the third of a 4-part educational series. We have one more webinar scheduled this month. Monday's webinar looks at the health economics of reusable versus single-use bronchoscope technology. Thank you all for your time and attending this webinar. It will be available for replay online in a few days. Have a good evening.